you for joining us and welcome to the CTSNet live webinar. Today we will discuss heart transplantation in 2021 and beyond, expanded donor criteria, DCD donation, and normothermic regional perfusion. If you have questions or comments you would like to submit to the panelists, please use the Q&A function on the Zoom window. Please note that this webinar is being recorded and the archived version will be available soon on the CTSNet website and YouTube channel. I'll now turn it over to today's moderator, Dr. Fiedler, to introduce herself and the panelists.
Thank you, Jazz, and thanks to CTSNet for hosting this exciting live webinar. It's my pleasure to moderate a discussion regarding heart transplantation in 2021 and beyond, expanded donor criteria, DCD donation, and normothermic regional perfusion. My name's Amy Fiedler. I'm an assistant professor of cardiac surgery at the University of Wisconsin in Madison. It is my distinct pleasure to welcome our group of panelists to today's discussion. Each of these panelists is an expert in heart transplantation and DCD heart donation. We have Dr. David D'Alessandro, an associate professor of cardiac surgery and the surgical director of heart transplant and mechanical circulatory support from the Massachusetts General Hospital. We have Dr. Ash Shah, a professor of surgery and the Alfred Blaylock Endowed Director and Chairman in the Department of Cardiac Surgery from Vanderbilt University Medical Center, and Jason Smith, an associate professor of cardiac surgery and the surgical director of heart transplant and mechanical circulatory support, also from the University of Wisconsin. So welcome everyone. Thank you for joining us, and I'm looking forward to an exciting discussion. Our agenda for today will be to touch upon the impact of the new Eunos allocation system on heart transplant programs throughout the country, discuss each of our experiences with respect to DCD heart transplantation, specifically touching upon TransMedics OCS experience with the recent trial, discussing normothermic regional perfusion, both ethical considerations and widespread applicability in the United States, and finally, we'll have some time to answer live questions from the audience. So without further ado, let's start. And so I'll start with Dr. Shah. Thank you again for joining us from Vanderbilt. And I'd like to ask you, how has the Eunos allocation system really impacted your heart transplant program at Vanderbilt?
Well, it's done a couple of things. First, I mean, we have had the busiest year we ever had last year, but I think from a volume standpoint, it really didn't change anything. If anything, we were busier, but it certainly changed the profile of the patients we were transplanting. So as most people know, but if you don't, the allocation system changed in such a way that it advantaged patients waiting that had a lot of that had temporary mechanical support. It deprioritized patients with durable ventricular assist devices, and so as a result, and somewhat, I think, part of our programmatic philosophy, we moved to listing more patients with intra-aortic balloon pumps, listing not a lot, but a few more patients who were on ECMO and supported with short-term devices. And it certainly altered the number of durable LVADs that we put in the course of our year. And so, so the impacts for us were significant in terms of the patient profile. Overall volumes were fine. Our distances, we traveled much longer. For sure, ischemic times longer for sure, and otherwise the outcomes were pretty similar. That would be our experience in a nutshell.
Mm-hmm. I hear you about the VAD volume. Dr. D'Alessandro, can you speak a little bit about the VAD volume that you've seen at MGH, and if as a result of the new allocation system, you've moved to more DT VADs as compared to BTT VADs?
Yeah, thank you, Amy, for inviting me to participate in this. It's certainly a pleasure to be here. I would echo all the observations that Ash just made. With respect to durable VADs, I think a lot of us are apprehensive about what's happened, in that there's now we are disincentivized to take a patient to VAD because their access to an organ goes, really way down. in the way that was not the case with the old allocation system. I think we collectively have had a really good experience using durable VADs to decongest, pulmonary pressures, and to take a patient that was, kind of marginal and stabilize them and make them good transplant candidates. And our results over the years have shown that that has been a successful strategy to getting sick patients safely through transplant. And now our VAD population looks different. As you mentioned, it's more DT VADs, less bridge VADs. And we're trying to get patients to transplant much more often through temporary assist devices. And the results appear that they're not going to be as good. It's a little bit conflicting. You kind of see, a lot of the survival curves look like they're worse, but not all of them. So I think the jury's still out a little bit, but certainly I, for one, and I think many of us are a little apprehensive about what it's going to look like in the years ahead.
And Dr. Smith, what is your observation been? Have you been transplanting more patients off of temporary mechanical support? Have you been shifting patients to VA ECMO in the preoperative period?
I again, thank you for inviting me as well. And I think we're all seeing very similar patterns of increased acute temporary support and decreased durable VAD implants for bridge to transplant. Although, my sense, I did change institutions in regions of the country in the middle of this whole allocation change. And there are a lot, I think, of regional differences and regional variations in how technologies are applied and how donors are not allocated so much as how they're utilized. And I think those regional variations in utilizations heavily impact how the programs have adapted to the new allocation system and adapted their mechanical support approach. In our practice here, I think we have certainly reduced our bridge to transplant volume with durable VADs. And I think probably are swinging back, the pendulum swinging back a little bit. I think we have seen increased acute mortality post-transplant. And some of that, not all of it, has been related to probably patients not being in as good a condition, as Dr. D'Alessandro said, going into transplant like we were seeing on patients supported for a long time on VAD therapy. So I suspect we'll see some leveling of that process, and it probably will never be what it was under this allocation system, but certainly I think we're still dealing with how best to apply this allocation system to our patients.
So you bring up an interesting point when you talk about the short-term outcomes. There have been recent publications demonstrating just that the short-term survival outcomes within the new allocation system may not be as good as the old allocation system. As a group, what are your predictions about long-term survival outcomes of patients who are receiving organs from the new allocation system?
Well, I don't want to speak for everyone, but I do think that the data shows that if you can get people through the first year, the long-term survival is essentially the same. And I think that's what we'll see long-term. For every other change we've made, that's what we've seen. But first, you have to have a first-year survival to have a long-term survival. So.
I think Jason's point is well taken. Almost every transplanted organ in human history has had much of the innovations happen in the first year. If you look at conditional survival, it doesn't even matter what the organ is. The long-term results are basically the same over the last decades. We haven't made big strides there. It'll be the first year, and not that dissimilar to what happened in lung. When lung went to their lung allocation score, which prioritized people on ECMO and even people on ventilators, there was this brief period of time where the outcomes weren't as good as they had been in the past. And then, teams sort of learn from their mistakes and adapt. And I think we're even seeing more recent data on in heart transplant outcomes that are getting better. I think all of us, we've definitely learned lessons about who is transplantable in this setting and who is not. And the other constituencies here are the cardiologists as well. So there are the patients, there are cardiologists, and so everybody's got to kind of work together. to figure out what's doable in your program's hands. I will say one of the things to also remember is that when we transplant these people a little bit more acutely, the operations, yeah, you're doing a lot more primary sternotomy heart transplants, which everybody in the OR is excited about. But I think those patients have a rougher time afterwards with the reconditioning, a little bit more renal failure. I mean, all these things that we don't track as well that we probably should comes back to haunt you a little bit. And so I think we'll keep getting better at it. So I don't know about the long-term piece of it. I think there are other things that are happening that we'll talk about today that will have a little bit more interesting impacts to long-term than I think the allocation system. But I do think, and I hope that people reassess this allocation system and think a little bit about what we're actually trying to accomplish here. And maybe if we started incorporating functional outcomes and not just 1-year survival, we'll move the needle a little bit on a more thoughtful allocation system. But I've been pretty publicly not excited about this system anyway, so it's not news.
Yeah, I think that those are all excellent points. And I think it's a nice segue into the next topic of conversation, which I think everyone's excited to hear about, which is with respect to DCD heart transplant. So each person who's on the panel today are considered experts in the field with respect to DCD heart transplant. And it's really exciting for the audience members to have the opportunity to hear your experiences, as DCD heart transplant has really accelerated in the United States since kind of late 2019 when the trial started. So Dr. D'Alessandro, why don't you tell us a little bit about your institutional experience with respect to DCD heart transplant and where you think the field is going to move going forward as we continue to use these organs?
Yeah. So I'll just start by saying our institutional experience with DCD transplants is in utilizing ex vivo perfusion, the TransMedics OCS machine. So I'm going to give it to you from that perspective. When we discussed that trial and we're planning that trial a few years ago, it was anticipated that we would have a 20 to 25% severe primary graft dysfunction rate with patients requiring ECMO. Which is what they were seeing in Europe and elsewhere, which I thought was going to be too high for the collective stomach of U.S. heart transplant. It turns out that it probably is going to be about 20 to 25%. I have not seen the trial results collectively, but our institutional experience in just about 30 patients is about 20%. That being said, they do just fine. As long as you support them adequately and appropriately early enough, they come off ECMO with normal graft function. So we've had, I would just summarize our experience that it's been very, very favorable. The wait times for people that are signed up for DCD go way down. It gives us an ability to take, lower risk patients that are lower down on the allocation system, and it gives them a very good opportunity to get good organs. There's been some learning about how to take care of those patients. Things are a little bit different. The perioperative courses are a little bit different. But when we compare our DCD population with our standard of care that we've had over the last many years, I see length of stay is actually a little bit shorter. Hospital length of stay is the same. Survival appears to be the same. Graft function appears to be the same. So the long-term metrics are all the same. So in my mind, when we stack up the many advantages, there aren't really many disadvantages other than you have to anticipate that more of these folks are going to need ECMO. And as long as you understand that and plan for it, then the outcomes are very good. And, when I consent patients for, DCD, I'm very optimistic, and I tell them that if I needed a heart or a family member needed a heart, I would absolutely encourage them to look at these hearts, and I think it's the right thing to do. So it's been great.
Great. And Dr. Smith, has your experience been similar? Have you seen that rate of ECMO utilization in the postoperative period and time to transplant, time on the list to time to organ acceptance or offer?
Sure. With regards to the first part of that question, in terms of acute postoperative support, we saw that rate in the EXPAND trial. In my experience in the EXPAND trial, we didn't experience quite that high rate in the DCD trial. We had fewer numbers than Mass General, so it may have been a number issue. But I think I would completely echo the fact that these organs all recover to so I wouldn't say all. We've had a high rate of recovery to a normal function and very successful patient experiences from the DCD trial. So we've been very happy also with our outcomes related to the use of DCD organs. What I would say has been most impressive is the reduction in waitlist time for patients consented. And David already alluded to this, but the SRTR reports show us that the number one indicator of overall patient outcome once they're listed for transplant is their waitlist time. And orders of magnitude reduction in waitlist time using DCD organs or hearts has been a major factor, I think, in our patient outcomes over the past 2 years. So I think I think that to me has been really impressive and probably the strongest reason that we've continued to pursue this effort.
Mm-hmm. Has the experience at Vanderbilt been similar, Dr. Shaw, in terms of the waitlist time, the performance of the grafts coming off of the OCS machine?
Yeah, so we have a kind of 50-50 split between using machine perfusion and NRP. Honestly, our experience has been pretty different. We have not had a lot of ECMO utilization at all. I think there's only been one. I think we've done 30 DCD hearts over the course of both between NRP and in the setting of the OCS trial. And the vast majority of, honestly, a couple of balloon pumps here and there, but really I've been actually very pleased with the allograft function to the point that I'm at least in my view, I'm somewhat convinced that these hearts are different than the brain dead donors. And again, our colleagues on the lung side have intimated such early in their experience using DCD donors. I think there is something different. In fact, if you look at if my experience with machine perfused brain dead hearts versus the DCD hearts, they come off the machines, they to me feel differently, that they're less boggy. They come off. We have not had as much PGD as compared to our conventionally recovered cold storage hearts. So I am actually pretty bullish on this. I think that I echo the sentiment that it definitely helps us get people transplanted. So we will, to just make a short story long, when we started the Hep C experience at Vanderbilt, it was largely because we had all these people with dysfunctional LVADs that were hemolyzing and having strokes, and we had to get them transplanted. So we're like, why don't we at least start with this group of patients? And getting them transplanted quickly was advantageous. And so similarly, we pivoted when we've got folks who are disadvantaged by the allocation scheme. We'll say really should think about DCD for them, just because it'll help them get transplanted. And that has been true. Now, obviously, as things get more widely adopted, that'll become less of a thing. But and also just to, our colleagues, in Europe and Australia really are the pioneers in this. I think they've firmly established that these are great hearts. They do work. Our task is to see, kind of writ large in the U.S., can we, make sure our PGD rates are all consistent and learn from each other. I do think when this trial comes out, it's a huge trial. It'll be the largest DCD trial, in the world, and we'll learn a lot. And last thing I'll say is, primary graft dysfunction is this sort of toxic thing that has it's pretty corrosive to all of transplantation, and we probably don't spend enough time thinking about how to mediate it. I think about it a lot because it keeps you up at night and ruins your day. And yeah, we can get the patients through it, and but to me, it's prevention of all that is critically important. So I have to say that our experience has been very different. Now it's not as big as Dave's, and I am, Jacob Schroeder at Duke probably has the largest experience, in the country right now, and I'm curious what their experience has been. But In short, it's been good. I think these are good hearts. And the really interesting thing will be long-term. Those long-term survivors, we started largely because of the Hep C experience doing a lot of IVUS, like a lot more than I ever thought we would start doing, just to look at intimal changes. So I'm going to be really curious. I'm sure we'll have that data. I hope everybody else is charting this, even at 30 days and 1 year, maybe we'll see a lot less intimal injury over time. But
Ash, do you have a sense of the difference between the function of the hearts using ex vivo versus NRP?
Yes. I think the NRPs are well, it's a little bit of an unfair comparison, to be honest, because we can get to this towards the end of the talk, but all of our NRP experience they've been pretty young donors. They're in their 20s, frankly. But the ischemic times are similar, but maybe even a little longer, honestly. Once they're on the machine, everything, everybody takes a step back and everything slows down. And one thing about in situ and NRP, it still has that same cadence of a cold storage heart because you have put it back on cold. So two big differences. I think our ischemic times would be shorter and they're younger, but our inotrope scores at 72 hours are a lot lower, frankly. So we've started calculating that as a measure of P. I learned that from Carmela Milano, that I think, how much epi you're on at 72 hours is probably just as important as, the few folks you have on ECMO and that kind of thing. And so we'll keep curating that. And I hope we do that in the DCD trial. I think we calculate inotrope scores. And so that'll be a very important piece of info. But I think they're better. I really do.
So Dr. Shaw, you bring up an interesting point that you say that many of the donors that you've accepted from an NRP DCD standpoint have been younger donors. I'd be interested what the group thinks, as DCD donation already is considered an expanded donor criteria. The widespread applicability of older, sicker, thicker DCD hearts to the pool. Do we think that these hearts have an opportunity to be transplanted? And do we think that them being DCD hearts actually presents a unique opportunity due to the ability to assess them prior to the implant?
And I certainly think, just to start, that age for me, if you were going to ask me, when do you think about NRP and when are you going to think about, Transmedics and the ex vivo platform, age is going to be one of the bigger kind of decision points right now for me. And I do think, as you alluded to, being able to give yourself a little bit of time to assess that organ does, I think, bring a lot of value to machine perfusion. And, if you look at the data, age over 40, if you have a donor over 40, it's a risk factor, no matter how good it looks. And so there's probably a lot of biologic reasons why these older hearts. And Dave, maybe remind me, was there an age cutoff in the DCD trial?
Yeah, it was 49.
49, right.
I do think there's a lot of very conservative programs out there that don't use older donors. We use a fair number of older donors, and I've clinically have not noticed a difference between a well investigated older donor with normal coronaries and normal function and a young donor. And biologically, I don't see an intuitive reason why it should be very different. The older donors are more likely to have more LVH because they have more hypertension as people get older, and we know that LVH is a problem for preservation injury. I think with ex vivo perfusion, it's a little bit less of a concern because it's a heart that's being perfused the whole time. So we in the U.S. don't have an experience with older donors in DCD. I imagine the UK does, and I don't remember what it is, but I personally would be willing to look at donors in their early mid 50s with normal function, no coronary disease, if you had access to that information. Unfortunately, often we don't have access to coronaries in the DCD population, and that's going to be the area of concern. Is people are just I don't know how good following lactates is to rule out moderate coronary disease. I believe it probably rules out severe coronary disease, but moderate coronary disease may not. And I don't want to give a patient a heart with moderate coronary disease. So that will remain a concern.
Yeah, I echo kind of all of those sentiments. I would say that for sure lactate does not rule out moderate or even severe coronary disease 100% of the time, as we found out in the EXPAND trial. So I think that's certainly true. I think in the early phases as we adopt DCD heart transplantation, I think really we'll probably continue to focus on the younger donors because the availability is so high in that cohort. But as this technology gets adopted, we're going to, I think, see what we saw with expanded criteria donors, that that these are usable organs. It takes more thought, takes more investigation, takes more planning, and better donor recipient matching. And I think as we apply those same things that we learned over the last decade, I think we will see better use of some of these expanded criteria DCD organs. But I think we're probably 5+ years from really having to do that. And until we have to, I think we probably will rely on the younger donor cohort.
And overall, what are each of your expectations with respect to increased transplant volume as a result of widespread applicability of DCD hearts into the pool? Do you believe that that could increase heart transplant volume by 30% as quoted in some studies in the United States, or do you think it's less than that?
Amy, one of my concerns is, I would say right now it appears to be at least that much, but it's the perspective of one of the centers doing it. Once it's like hepatitis. When there were very few of us using hepatitis organs, that was a huge lift to our patients. But as that diffused out to the community, it's infrequent now to get a hepatitis organ. I think we'll see the same thing with DCD if everybody decides to get into that, utilizing them. One area that I have a concern about is that I think that the DCD population may eat into the standard brain dead population, because as procurement organizations get more comfortable with DCD, everybody's a DCD until they progress to brain death. And so if you allocate those organs earlier, you're just taking away from the brain death pool. So I think that it may be 30%, but my concern is that the other pool may shrink at the same time. So I'm not sure what it will ultimately do to our numbers.
I think one other thing to consider is that the recipient population really drives, I think for a long time we've operated under the rubric that it's a donor availability problem in transplant, which has been true, I think, clearly. But as these alternatives to standard criteria brain dead donors have come along, and the ability to transplant more quickly has come along from various advances, I think we've also seen the recipient side of the equation become a factor in terms of, as your volumes shoot up, you start to relax your recipient criteria, or you go out looking for recipients that you might not have transplanted before. And I think that has an impact. And I don't think we've defined what that's going to be on the field yet, what that means in terms of our long-term survival, our more early survival. And so it's a paradigm changing, I think, in a small p paradigm kind of way, how we do donor recipient matching. And that paradigm shift, I think, has not completed. And I don't think we know yet how that's going to impact the whole process.
I don't think it'll be as dramatic, largely because, DCD recovery, we've made recovery more complicated and it's more expensive. And, I think that it's not, we've got a big crew at Vanderbilt, and it still stresses us to send out teams all the time running around with all this equipment and big trucks. Now we had to refit our planes for all this stuff, and everybody's running around like crazy. And it's a lot of money, time, and energy and risk. And I don't think it'll be as widely adopted. If you look at Hep C, that's something that could have been widely adopted like crazy. There's nothing complicated about it, but it hasn't been, honestly, because it's still a little bit more effort and energy and expense, and that prevents programs from being super high adopters. I think that you'll see big programs be full on, and they'll invest in the resources to get it done. But I think the vast majority of heart transplants are done in programs that do less than 20 heart transplants a year. So if you're that program and you've got a lot of other demands on your resources and ICU beds and everything else, Are you really going to, invest in that? So I think we need to make this more sensible. So I think it will expand if we are really thoughtful, nationally, and say, okay, if we're going to do this, then let's really think about helping each other out on recovering these organs, having a best practice, having some consistency in assessing the organs, and that way we can, get them out there. I mean, until we do that, I think you're still going to be. It's not going to be 30%. It could be. It absolutely could be. But I think we got to get some of these administrative and logistical hurdles tackled before it makes sense for everybody to do it. And I think they should, but it still has to be sensible.
Yeah.
I think that brings up an interesting point in terms of the learning curve associated with all this too. I think, we certainly learned a lot in the expand trial, and then continue to learn in the OCS DCD trial, and continue to learn as we get ready to start an NRP program. So I think you're totally right. There's a ton of logistic components to this, and then a ton of sort of questions that have to be answered about management and how best to assess organs, and that learning curve we're still on the steep part of, I think. And you're right, until we get over that, it's going to be, adoption will probably not be as broad.
Yeah, I think all those points spin off nicely into a discussion about NRP. So with Dr. Shaw retrofitting his planes and bringing out a big crew to do more extensive procurements, I'd like to hear, as everyone knows, Vanderbilt has really been at the forefront in the United States with respect to implementing NRP. So briefly about the institutional experience, and then we can also have a discussion prior to getting more involved about organ assessment, about ethical considerations and how that has been handled in terms of public perception and optics when you're comparing a DCD heart in a box to NRP.
Well, so obviously we took our lead, frankly, from the Europeans. So the Papworth group, Dr. Large and Steve Suey, and those guys really led the way in situ reanimation and recovery of organs. So they deserve a phenomenal amount of credit for that work that they did. And that's and then we were in the DCD trial. We were kind of late in the DCD trial, and then the trial ended. And so we found ourselves thinking, wow, these hearts actually work great. We've got a lot of demand. So, there's this accepted practice that's going on in Europe. It makes a whole lot of sense for us to continue. So institutionally, we talked about it at the highest levels, and our senior leadership agreed that this was important. So we set out to do this, but in a couple of fundamentally different ways, which are very uniquely American ways, I think, is that given the distances involved, it wasn't practical where we are to move the donors. So that's the first thing. So we had to be able to deploy our teams out with a very efficient circuit and a setup. We also had to reassure the abdominal teams that this made sense. So within the family, you had to make sure all this stuff is going to work. How do you manage air? This is kind of a big deal. Although actually, University of Wisconsin has an experience with using ECMO for DCD, long ago. So that idea isn't a new one. But as you know, ECMO doesn't manage air very well. And so if you have flow problems early, the abdominal teams are going to freak out appropriately and not be so happy with it. So we had some technical things to get over. Got that managed, and then obviously we put into practice as a change of clinical practice, and we're after a couple of our first cases went great. We had a couple in the middle that didn't go so great, and then from there on in we've been pretty consistent. We've got a good system to do it, and so as a result, the next constituency is talking to the OPOs. And then finally, obviously, the public side of this is something we'll talk about at the end. But ultimately, it's been a great experience for us. It has allowed us to take advantage of a lot of great organs. As I said, our average inotrope score at 72 hours in this group of patients was 8, which is probably better than our brain dead donor hearts at 72 hours, frankly. And And again, the ability to get people transplanted was also pretty advantageous. So I think we have put together a reproducible system. It is a little bit of a crew that goes out, but and you cannot send out, very inexperienced people. You need a group of people that work together every day, because it takes a lot of coordination, efficiency, and you have to be respectful of the abdominal teams. And then the fundamental thing with in situ reanimation is managing death and what death means, and making sure everybody's comfortable with the idea that this person is dead, and you are honoring their wishes and the family's wishes to donate. And this mechanism to do it does involve restoring circulation, which is a tough one to kind of wrap your head around a little bit. But by eliminating blood flow to the brain, you do continue to respect the idea of death, of an irreversible state. And that's really the fundamental kind of components to this process, all of which has to be addressed. And our crew kind of took it on as a challenge and has done a really remarkable job. But it is reproducible. It is certainly has delivered very high quality organs. And we'll talk about this. The elimination of warm ischemia for the abdominal teams will prove to be another game changer for them, because their experience in DCD is not great. And the many liver programs won't do DCD because the results are not so great. And this, by eliminating that warm ischemia, their early functions of their grafts are quite good. And the experience in Europe seems to support that. And then our small experience here, 17 livers recovered this way. They've really, really done well. And these are from not all Vanderbilt teams. These are all over the country. We're kind of pooling that experience also.
Now, can we talk a little bit about donor organ assessment on NRP versus the OCS? So how exactly for everyone, how would you ideally assess these grafts? A SWAN, an echo, visual assessment, gases? Yeah. What's the best way to do that to optimize use?
So the experience in Europe is a very heavy on cardiac outputs and a lot of invasive things. We did not think that was going to be very practical in the United States. You're in a lot of small hospitals. I mean, everybody knows sometimes you can't even get a sternal saw in some of these hospitals. And so I didn't think that was going to be very practical. So we basically, because of how young the donors are, and as our friend John Haft would say, it turns out to be an eCPR case. And you basically get, the heart comes back, it's going to be okay, has been the hypothesis that we went into this with. And it's certainly borne out that the hearts almost always come back. It's pretty rare for us to actually defibrillate these hearts, believe it or not. Once the blood flow is restored, they kind of pop back. But even then, it's pretty obvious. Now, we have started getting a few lactates here and there, but honestly, it's hard to know what to make of them because the liver was ischemic. I don't know. So it's going to be an unsatisfying answer, actually, that we've gone with the eyeball test. And sometimes the guys will send a video, and I'll look on my phone and go, looks good, just take it. And so far that's worked out fine. I think as we stretch out and start thinking about other types of donors, that's probably not going to cut it. But so far it's been fine. And maybe the argument is, frankly, you had this, our time from, when death is declared, your hands off, to restoring circulation, honestly is under 5 minutes. So, so we've minimized warm ischemic injury, so that's not on the table. So really, it's really just the usual, and you've got a non-brain dead donor, which I think is that's advantageous to these hearts.
Dr. D'Alessandro, what do you think about utilization of NRP donors? Is this something that your institution is interested in moving forward with, and how would you go about assessing these grafts?
Yeah, I mean, there's a lot of reasons why advantages to NRP, as Ash just articulated. For me personally, it just doesn't sit super well with me. I know that makes a lot of people unhappy. I think you can easily construct a good argument why this is ethically fine. I think the way the practice is done around the world is heterogeneous. There's, and there was a publication a couple of years ago where they're taking people to the operating room and they're cannulating them under general anesthesia and then removing the ventilation. That's not the way we do it here, but that's the way some people are doing it. And I think I don't believe that's a practice that we ought to support. It's hard to imagine that you can consistently open somebody, cannulate them, control the head vessels, and get them on bypass in 5 minutes. That's hard for me to imagine when you're not sending very experienced senior surgeons. And so I don't think that's going to be everybody's experience. I think for regional utilization and sharing and all that, I think you can make a really good argument how this could work across the entire country with a network. And Nader Mozami has proposed that, and he's been a big advocate for this. And I think that could be a way that everybody could more evenly utilize these types of hearts. I think for a single institution, we don't have the bandwidth to the program that Ash just described. That's a lot of people, a lot of equipment. We don't have it. We've been very happy with the OCS machine. I think the one big advantage that OCS has is that you can go a long way away and you don't have to rely on cold storage to preserve the organ coming back. And that's a big advantage for us. We take a lot of our organs from a long way away, and that's been great. NRP, you can't do that. I think the big advantage of NRP is it gives you the ability to have invasive hemodynamics on a loaded working heart. That's been the big advantage. And I'm a little surprised to hear, Ash, that you don't take advantage of that, but I could see why that would be the case. On the OCS, you don't have that advantage. You got an unloaded, non-working heart. You have to rely only on lactate, which turns out to be a pretty good measure of function and heart health, I think. So again, for us, OCS has been successful. It's a lot of advantages to that, certainly a lot of cost, but it's easier for us, and we presently don't have a plan to start doing NRP in the near future.
And finally, Dr. Smith, as the leader of a program that's contemplating the institution of NRP soon, what are your thoughts about widespread applicability, and how do you plan on assessing these organs?
Sure. Well, I think, for the reasons David just illuminated and Ash lined out before, I think widespread applicability is going to be slow because of the resource demand to do it, and the practical skill it takes to make this happen and practice. I think procurement in general is becoming more and more of a specialty specific talent, and no longer will we be able to send the random junior faculty not involved in transplant to do procurements, because they are getting more and more complex, both technically and also from a decision-making standpoint. So I think, we're going to be sending transplant professionals now to do these things. And so that is an additional resource and expense, I think. But we'll make a lot of junior faculty across the country very happy, I think. What, in relation to what we're going to do to assess organs, I think, is try to find that middle ground. I think, the eyeball test really is the gut check, right? And I think ultimately that's what a lot of us make decisions based on. But having more data, I think it's tough to you can't drag an echo machine to do a TEE at a hospital that doesn't have echo capability, or at least not easily. Maybe technological advances with handheld echo and some disposable echo probes. We may get to that point where that's easy to do, but right now that's not so easy. And, invasive hemodynamics, for the same reason, can be a little bit challenging, maybe not quite as challenging, but having the right equipment and personnel to do that. Excuse me. So one thing we're thinking about is pulmonary, excuse me, pulmonary arterial and venous gases as our method of assessing.
Okay over there.
Sorry, I'll leave it there.
And I will add that I think those are all going to be, useful things. Biomarkers will have to be what we use, not echo. I mean, all the echoes are fine, right? We go into this, the echoes were fine. That's why we sent the team to go look. I mean, and then you're staring at the heart after you implant it with an EF of 10, and you're like, but I thought the echo was fine. So and we get cardiac outputs beforehand, and the cardiac output's 10 liters in the donor, and then it's you're on the index is 1 post-op. So I think a lot of the things we've hung our hat on are probably inadequate, period. And no better than the eyeball test. But I'm not suggesting the eyeball test is the gold standard. This is an area we need to work on.
Yeah, and you bring up a lot of important points with regards to assessment of the organs and the limitations that we have currently with the OCS machine strictly looking at lactate. Yeah. And the ability of NRP to provide us with additional functional assessment data. Thinking about that, one of the differences in the way that NRP has been performed in the United States when we look at our European colleagues is taking the heart out and putting it on ice and bringing it back to the center. So Dr. Shaw, with your experience with NRP at Vanderbilt, do you have an upper limit of the cold ischemic time that you're willing to tolerate for these NRP hearts?
That actually not anymore, honestly. I think that's I mean, the really long distance thing. So for us in Nashville, we really relied on machine perfusion to get out to Nevada and sort of remote parts of Texas. Or if we thought that our explant was going to take a long time, I mean, I think that it's not just distance. To me, I use some of the machine perfusion just to work out some of the logistical problems. So I think that those ultra long flights for sure. But our NRP experience has got ischemic times of 2 hours, even 3 hours, and they've been fine. Again, they're younger hearts that we wouldn't expect. I do think there's a difference between younger hearts and the older hearts. I mean, they do behave differently, at least in my experience. So I think that the distance won't be as much of an issue. I still think that when we do a deep dive and a big enough data set on primary graft dysfunction with good definitions of PGD, we're going to really have to come back and ask ourselves, we need better biomarkers to kind of make a decision here. And all the old dogma, I don't think is going to be relevant, particularly if we start looking at functional outcomes. We can drag people through a year of life. If you look, there's a great paper in AJT a long time ago that if you look at hazards of death, the biggest hazard of death is getting to month 13. Like all of a sudden at month 13, everybody starts dying, and largely because we drag people through because we're worried about 1-year outcomes. And then all of a sudden, oh, this is terrible. We shouldn't prolong misery anymore. And I think if we pivot and start talking about functional outcomes, or really look at this IVUS data carefully with good controls, which I think we're not doing a good job of yet, but to really understand what we're doing, to the coronary intima, we're going to go back and say, we don't know what we're thinking about here. And we need much better biomarkers, which actually supports the machine perfusion, greatly. That's the opportunity, not only to get better biomarker work, but to start manipulating these organs and start doing something, and rather than just stare at them, for long periods of time.
Dr. D'Alessandro, you were about to say something.
No, Amy was, I think, trying to gauge your comfort with long ischemic times, and you copped out with 2 to 3 hours. What about 4 hours and 5 hours? Would you do that?
I probably wouldn't.
Yeah.
Not now.
Dr.
Right.
Smith,
Is that a function of you don't have to, or a function of you wouldn't do that? Like if they were the only NRP you could get for a month, would you go 4 hours or 5 hours?
I probably, yeah. Right now, that's a function of, my capacity, that I don't have to do that I have options. That's pure speculation. Would I be willing to do it for a 18-year-old heart in California? I'd probably for a patient that was desperate, as all our patients are, because lest we forget, this is, those folks are pretty desperate waiting for heart transplants. I think I would, but knowing that that's going out on a limb for sure. And we don't know what would happen.
And Dr. Shaw, one of the things that you mentioned when we began this discussion surrounding NRP is the kind of secondary benefit of the abdominal organs. So the liver is being better perfused. Can you touch on that experience and how do we think NRP is going to benefit solid organ transplantation, not just thoracic organ transplantation in the United States in the future?
Yeah, so it's a great point, and it may be a bigger driver of NRP than what we're interested in. Because remember, thoracic transplant is a small part of transplantation in the world. The NRP experience, which has been around for a long time in Europe, was sort of okay, and so what they had been doing was doing femoral cannulation by the abdominal teams, and they'd find somebody to cross clamp the aorta, again, to prevent brain flow in the chest or someplace. And there was an experience out of Spain that was okay. And when they say okay, we're talking about primary graft dysfunction of the livers and then biliary complications. That really is the stigmata of a dysfunctional allograft for poor preservation and ischemic injury. But increasingly, and this is out of the UK experience, and then back in Europe again, NRP has been associated with better outcomes, frankly, for the abdominals. And I think as compared to their current state, if you could tell them, and one thing I will tell you that our NRP experience, unlike the Europeans, it's no more than 50 minutes on circuit. And we even tell the abdominal guys, look, you got 50 minutes. We're taking this heart after that. Because what does happen is the longer you're on these circuits, and there is a fair amount of bleeding that's going on because, again, you cannulated when there was, under circ arrest, and so everything looks great, and you feel like you're the best surgeon in the world, and then all of a sudden when blood starts entering the field, it's a problem. And so you can't let the abdominal teams have at it, there's no dividing the liver in situ, that's not happening. And you say, look, you've got a limited amount of time, but even that limited amount of time is better than their, the complexities of getting abdominal recoveries under those conditions and the warm ischemic time. So I think they are going to see much better outcomes with antegrade perfusion done with good flows throughout. That's what we offer with a thoracic approach, is that because we've incorporated vacuum, incorporated a cardiotomy reservoir. So even with the bleeding, we're able to maintain liters of blood flow and keep a patient stable, the donor stable. I think what'll bear out is that their outcomes will be better. It'll allow them to feel more comfortable using DCD, and then you're going to see a lot more use. Whether or not they take thoracics, I think they're going to ask us to, hey, can you go on in less than 5 minutes and perfuse this donor, because it really is going to make a big difference for them.
Mm-hmm. Well, go ahead, Dr. Smith.
I was just going to ask one question about your assessment. Ash, are you making your decision to move forward with the organ while the heart is still on ECMO support, or are you waiting until you wean off, or are you even weaning off ECMO support to make that decision?
Yeah, it's a great question. So we do. So when we go on, we put a line in the pulmonary artery first of all to kind of act as a vent because it's faster and easier. We kind of let the resuscitative period go. Frankly, most of these hearts all bounce back pretty quickly. And then towards that end of my 50 minutes kind of mark, we'll reload the heart and stare at it for a little bit and just make sure the RV doesn't blow. Just all the usual things that we look at. We've done some mixed venous sampling. Again, with the abdominal teams working, it's kind of hard to know what to make of some of the biochemistry at that point. But yeah, we do reload it. I haven't done that just to make sure that RV doesn't blow. And we can kind of control things with that PA vent, not to get too technical about it, but that allows you to make sure that you don't distend the RV or injure the lungs. The other the complexity that we have is that if they're not taking lungs, then they're just going to leave the lungs unventilated. Well, that's going to wreck your right ventricle if you load them, and that's why we introduced the PA vent in there. If you're taking the lungs, we haven't worried so much because then they'll start ventilating them at the time. But we have to think about that a little bit. I don't know. There've only been 3 lung donors in our series of 17 or so NRP cases. We've used all the livers. They've done fine in the kidneys. They've only done 3 lungs. So I don't know what'll become of that. They've got a pretty curated sort of experience in the lung side of things. I do worry a little bit that introducing circulation and the fair amount of transfusions that go on during that period of time may potentially be injurious to them, but to some extent they're protected as well because they're on circuit. Not to get too far off what you're asking, but yes, we do load them for a brief period of time.
So everyone, this has been a really informative discussion surrounding DCD and NRP. We have a number of participants that have asked questions in the live chat, and we've selected a few of them that we hope can be addressed by our panelists. So one of the questions is that Dr. D'Alessandro commented that lactate is a surrogate for function on the OCS machine. Can the other surgeons comment on the role of lactate in OCS and how this is driving your decision as to whether to use the organ or not?
Sure. I think lactate's really the only quantitative measure we have on the OCS other than sort of the pressure flow relationship. And so lactate plays an important role for all of us, I think, in that respect. With DCDs, it's a little different than it was, I think, with our expand cohort or expanded criteria donors alone, in that the lactate levels can be much higher and still represent a usable organ. I think really what we're learning, and probably mostly from the European experience again, is that it's the trend in the lactates that's really the most important. And I think all of us have recognized that and follow that.
I think that's been my experience too, is that it's more the kinetics of the lactate. Now the trial has certain criteria, but I think if you ask a lot of, again, I think Jacob Schroeder's experience and the experience outside of the United States, lactate is a little bit less involved. I mean, it's just yet another piece of data. I personally think it's helpful and interesting, but I do think that there's a growing experience of moving away from just isolated lactates and more about the kinetics of the lactates.
Okay. And we had touched upon how quickly, Dr. Shah, your team is seemingly able to open and get the patient on bypass and clamping the head and excluding the brain circulation. Can you comment a bit more? And this is a question coming directly from an OPO medical director regarding the timing of cannulation, excluding brain circulation, and starting the circuit in your NRP experience.
Yeah, you can do it in 5 minutes. I know it sounds crazy, but it's doable. And because you got to remember, it's like doing a circ arrest case. There's no blood to get in your way. And the biggest problem is the heart being distended. So the first thing we do is we just stick a cannula in the right atrium, and without a purse string. So as soon as you start draining that patient, everything else gets easier. And then you've got and you do have to it's a little practice. And I would send the same team every time to go do this. It's doable. We're going to try to start incorporating some staplers for the head vessels. And I think we can be able to do that pretty quickly. I mean, again, without any circulation, you can get around all the head vessels really quickly and put a clamp on them. Mm-hmm. It is 5 minutes is a lot longer than you might imagine to do it under those conditions. It does seem intimidating at first, but it's totally doable. And there'll be other things that we'll try to build into, to get faster and more efficient. But if you told the abdominal teams that you needed 5 minutes or even 8 minutes, they'd be like, okay, that's a lot better than what we're normally dealing with,
Sure, and we actually have a question from Professor Dark in the UK asking directly about lung retrieval and any concerns about this after NRP.
I have one. It's always good to hear from Professor Dark, and I've learned a lot from him over the years. I think that my only worry is a little bit about the transfusions. The donors are getting a lot of volume once the circulation's restarted. We've, again, incorporated a pulmonary artery vent to try to protect some of these lungs. But so far, all the lungs that have been retrieved, there's only been 3 so far. And not because of something that happened during the recovery, but rather they were just declined ahead of time, just to be clear. They've worked fine so far. But that's the thing that I worry about, is that if they're getting transfusions during that period. And it's the other reason I've just said, look, you only have a limited amount of time, because 2 hours, which I believe some of the experience out of Europe was that they would have these folks on for hours, kind of assessing them. I said that's not doable in the United States. We got to be in and out in a relatively reasonable period of time. And just to remember, there is also still, maybe for historical interest, an experience of direct procurement. They do this in the PED side a little bit. of a DCD where you just take it, put it on ice and take it. I don't think that'll be true in adults and relevant, but I'll say one last pitch is that the AATS is putting together a consensus document and expert opinions as best as we can. And hopefully that'll provide flesh out a lot of details, you know, on all these topics. So stay tuned for that.
Now we're reaching the end of time. This has been an incredibly informative and exciting discussion. I want to take a moment to thank all of our panelists as well as our live viewers for joining us today, and to remind everyone that a recording of this webinar will be available on CTSNet probably by the end of the weekend. So thank you, Dr. Shaw, Dr. Smith, Dr. D'Alessandro, and Dr. Bomaretti for being our digital moderator. And I'll turn it over to Jazz from CTSNet to close us out.
Thank you to Dr. Fiedler and our panelists for today's discussion. The archived version of the recorded event will be available shortly on the CTSNet website and YouTube channel. Please visit ctsnet.org to explore past recorded live events and learn about upcoming events on the CTSNet events calendar.